Robert, one of the things that I know Lisa is going to want to ask you, maybe I'll jump the gun a little bit. There have been articles out, particularly from the Scandinavian literature, that perhaps because of breast screening, we're actually over-treating breast cancer. And I'd be real interested in your comments on that.
Yeah, so there's really two ways I think to think about overtreatment, and I think you can speak to this with much more authority than I can as a treating clinician. Clearly, we treat breast cancer fairly aggressively, and some women are actually receive more aggressive treatment than they ultimately may need, but it's what we have to do because we really can't identify which among these women truly need that kind of aggressive treatment and which do not. And ultimately, with better research, we'll be able to distinguish women who could have a maybe more moderate course of therapy than those who maybe need really very, very aggressive therapy. The issue of overtreatment that is, I guess, more predominant now in the context of its harms is the possibility that mammography will identify a breast cancer that, based upon all the criteria that we apply in the pathology lab, it is a malignancy, it is an invasive breast cancer, but that if that woman had never been screened, we never would have known about that cancer. That cancer would have just hung out for the rest of that woman's life, perhaps it would have regressed, but ultimately it would never have created symptoms and it never would have threatened her life. To the degree that we cannot identify those cancers in the lab, the only way we can determine whether or not overdiagnosis is taking place is statistically. In other words, we look at incidence rates over long periods of time in women who were exposed to screening and women who were not, and we look for an imbalance in what we might say is the expected rate. And what's remarkable now in the published literature is how wide those estimates are. From my perspective, when these studies are done properly, in other words, when we address a number of what we refer to as covariates, challenges in trends and incidence, whether we overcome the statistically the big increase in incidence that's simply associated with screening, when we find cases earlier than we otherwise would, then those estimates of overdiagnosis are really very small. They're less than 10%. They're probably mostly confined to ductal carcinoma in situ, which means that the likelihood of very, very aggressive treatment associated with a cancer that wouldn't have ever been a problem is probably very uncommon.
Hi, I'm Dr. Jay Harness, and I want to share with you important information that I believe that every newly diagnosed patient with breast cancer needs to know.
I'm a breast cancer survivor.
I am a breast cancer survivor.
I am a breast cancer survivor.
And I want every woman to know
about personalized breast cancer treatment
and the genomic test.
A test that helps guide a woman and her doctor
to the best treatment options for her.
Pass it on.